Hello, my dear. I'm Dr. Alaa Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Today, I wanted to discuss with you CTG quiz. CTG is the abbreviation of cardiotocography, and it is one of the most important fetal well-being tests done late in pregnancy and during labor. Okay? Okay. This is how CTG look, and the question is comment on this CTG. Okay, of course, when you have this quiz, this words is not written here, of course, but I did it for explanation to you how to read and how to comment on CTG. So, what are the items important to read CTG? First, before you start to read CTG, you should determine if the patient is high risk or low risk. Okay? Because high risk or low risk, after reading these parameters, you can decide some interventions because the patient has a high risk, for example. Okay? You should take a decision. So, you should first know if the patient is high or low risk. Then, this is the items we wanted to comment on CTG. The number of contractions per 10 minutes, the baseline fetal heart rate, the beat-to-beat variability, the accelerations, decelerations, and lastly, the overall impression, and say if this CTG reassuring or suspicious or abnormal. Okay, let us start to comment on this CTG. First, contractions. We know that we put 2 electrodes on the pregnant woman abdomen, one for contraction and one for fetal heart rate tracing or CTG tracing. Okay? Okay. Contraction, the blue one, and the fetal heart rate tracing is the red one. Okay? Let us start with contractions. How many contractions per 10 minutes? The horizontal axis here is the time per minute, while the vertical axis is beat per minute, fetal heartbeat per minute. Okay? Okay. And the horizontal is the time per minute. So this is, in this axis, is 30 minutes. Okay. The first 10 minutes, 3 contraction, as you see. The last 10 minutes, also 3 contractions, as you see. This peak is 1 contraction, so we have here 3 contraction per 10 minutes. Okay. This is the first item in CTG you should comment on. Okay. Let us go to CTG tracing and the fetal heart rate. We will start with the basal fetal heart rate. How to know the basal fetal heart rate? The average fetal heart rate. Search for the average fetal heart rate. In which line? And the number beside it. As you see, don't put the deceleration or acceleration, this peaks with you. Take the average, especially from the last 10 minutes. This is the last 10 minutes. What is the average? Look to this area. This is the average. Look here. You will find it about 120. Okay? So this is the average. So the basal fetal heart rate here, 120. Okay. This is the second item after contraction. Basal fetal heart rate. Second item. Accelerations. Accelerations. Where is the accelerations? This peaks is the acceleration. What is the acceleration? Rapid increase in fetal heart rate more than 15 beats per minute, lasting for more than 15 seconds. Okay? Okay. As you see here, the basal is 120 and the peak reach 150 in most acceleration here. So it is about 30 or between 140 to 150. So say 145, so it is about 25. So the acceleration here from the basal, which is 120, is 25. So it is more than 15 beat per minute. And the lasting more than 15 seconds. Each square is 1 minute. Okay? So here it lasts about near to 1 minute. Here less than 1 minute, about 30 seconds. So it should be more than 15 seconds. Okay? So all these accelerations go with the definition that the increase in fetal heart rate more than 15 per minute and the last for more than 15 seconds. Okay? Acceleration during uterine contraction, if you see here, this is uterine contraction and this is acceleration at the same moment. And this is uterine contraction and there is acceleration at the same moment. This is a very good sign of fetal health. So if you see with contraction, acceleration, this is a very good sign that the fetal health is well and very good. Okay? Okay. Also, acceleration with fetal movement is a good sign also about the fetal well-being. So, acceleration with uterine contraction and the acceleration with fetal movement, both of them is a good sign that the fetus is very good. Okay? Okay. Let us go to the next, which is beat-to-beat variability. Beat-to-beat variability. What is beat-to-beat variability? The relation from beat to beat, the change in the fetal heart rate between beat to beat. From this one to this one. From this area to this area. How many? Look to this on the left side. It should be between 5 to 25 beat per minute. So, the change in the fetal heart rate from beat to beat, as in this line, and also as I mark it in black here, from this to this, and from this to this, this is the change in the fetal heart rate from beat to beat. This is called variability. Variability is very important, and the normal range between 5 to 25. If less than 5 and lasting for more than 30 minutes, it is abnormal. If it is more than 25 and lasting more than 50 minutes, it is abnormal. The CTG considered abnormal and there is problem as regard the fetal well-being. Okay? Okay. So this is called beat-to-beat variability. Next is the deceleration. What is the deceleration? It is the reverse of acceleration. We said acceleration, increase in the fetal heart, sudden increase in fetal heart. But deceleration, sudden drop in the fetal heart rate, more than 15 beat per minute, and the last more than 15 seconds. As you see, this is one of the deceleration. Okay? Okay. Look to the basal. We said basal 120 nearly, and the drop reach 100, so it is more than 15 beats, it is about 20. This deceleration drop to 100 beat per minute. Okay, so it goes with the definition. What about the types of deceleration? I have early deceleration, which is physiological, and no problem with early deceleration, and delayed deceleration, which denoting fetal distress and the fetal hypoxia and acidosis and placental insufficiency, and variable deceleration. variable deceleration may occur normally as this one and may carry certain criteria or certain characteristics make it suspicious that the baby is in stress and there is a problem in the baby. Okay, like what? Variable deceleration with shoulders, elevation, peak, then drop, then again elevation, then another peak. This is called the shoulder. It is not present here. If it takes W shape, if it drop and doesn't reach the baseline again, also is alarming type of variable deceleration. Okay. What about early and late? We wanna to understand them little more. Okay. You see this contraction? If this deceleration happen with the start of contraction and reach the peak with the peak of contraction in this area, and the drop and regain the baseline with the drop of contraction. So follow the contraction at the start, at the peak, and the end. This is called early deceleration, and due to this is physiological and due to head compression during head descent during labor and due to increased vagal tone, and it is physiological. It is not a fetal distress. Early deceleration, no problem with that. But the problem comes with late deceleration. How can I read it on CTG? Late deceleration doesn't start with the start of contraction, but start with the peak of contraction. Imagine this is the peak of contraction, start here. The increase will be here, then reach the peak with the end of contraction and continue after contraction. Okay? So it starts with the peak of contraction and end after the end of contraction. And if you are just hearing with sonic aid or with Pinard, after the contraction disappear, you will find the late deceleration. While early deceleration, you can detect the fetal heart rate drop during contraction by sonic aid also. So by CTG, you will see the peak of the start of deceleration with the start of contraction and the peak of deceleration with the peak of contraction. This is early deceleration and this is physiological, as I said. But late deceleration start with the peak of contraction and continue even after relief of uterine contraction. The deceleration still continue after that. Okay? So late deceleration denoting fetal distress. And the variable deceleration with certain characteristics also denoting fetal problem or fetal distress. But this type of deceleration is a variable deceleration, is a sporadic one, carry no hazardous criteria. This is known. Okay? Okay. So up till now, we said we will start to define the patient who at risk, high risk or low risk. Then we will comment on contraction, how many contraction per 10 minutes. We found here 3 contraction per 10 minutes, as you see, from 20 minutes to 30, 3 contraction. And from 1 minute to 10, 3 contractions. This is 3 contraction per 10 minutes. Then we said we will start with the basal fetal heart rate, and we said we will take the average. We will not lock to the acceleration or deceleration. We will lock to the average at the baseline here. What is the baseline? Lock to the average in the last 10 minutes. You will find it approaching nearly 120. Okay? Okay. Then we will comment on acceleration. We found the acceleration and we did comment also on deceleration. And we did comment on beat to beat variability. Is the fetal heart rate change from beat to beat, as in this area. connect it by this arrow from beat to beat. Okay, and this also a sign that the baby is doing very well if beat to beat variability is present within the normal range, which lies between 5 to 25 beat per minute. Okay, okay. What else? Sometimes you didn't see beat to beat variability, you don't see the CTG like that. Sometimes you see it like sinusoidal rhythm, just waves, waves similar in shape, no beat to beat variability, no acceleration, just waves. This is called sinusoid pattern or sinusoid pattern CTG. Okay, this can occur in very distressful condition, in acute fetal distress, and may need immediate intervention, okay, because it is very dangerous. But sometimes it can happen physiologically. How it can happen physiological? With some sucking by the baby. Imagine with some sucking you can see sinusoid pattern, but it will be transient, not filling all the 30 minutes, just a small part of CTG. You will find sinusoidal pattern, then the normal will appear again. So this is not pathologic, this is just some sucking by the baby can cause this sinusoid pattern. What are the factors that can decrease beat-to-beat variability? Sleep. Baby is asleep, the sleep. Also some drugs like morphine, okay, like magnesium sulfate can cause decreased variability, beat-to-beat variability, okay? And also fetal distress, as we mentioned before. Fetal hypoxia and placental also insufficiency and fetal distress. Okay, so now we covered the, we covered the items determining the patient, our patient first high or low risk, then contraction, baseline fetal heart rate, variability, acceleration, deceleration. Lastly, we need to reach the overall impression. What is our overall impression about the previous CTG? Is it reassuring or suspicious or abnormal? I'm saying the previous CTG was reassuring because there is normal beat-to-beat variability, normal acceleration. The deceleration present is sporadic one, is variable deceleration, no problem with that. And the basal fetal heart rate within normal range, 120. I forgot to tell you, when we say, as regard the basal fetal heart rate abnormal, we say suspicious first if it is 160 to 180 or 110 to 100. This is suspicious. And we will say abnormal if it is less than 100 bradycardia or more than 180 tachycardia. Okay? So this is as regard the basal fetal heart rate. Okay? Okay. So after we finish all items, basal fetal heart rate, acceleration, deceleration, beat-to-beat variability, okay? We finished everything, and now we wanted to comment. The previous CTG was reassuring. Yes. Okay. This suspicious or non-reassuring, in other words, you can see it in some textbook, suspicious or non-reassuring. And lastly, the abnormal, which is the more dangerous one. Abnormal, you will find certain character. Like what? Like deceleration, late deceleration, repeated, over time, like long-term deceleration continue for 3 minutes, for example, or more. Okay? Like beat to beat variability less than 5 beat per minute and continue more than 30 minutes. Or beat to beat variability more than 25 and continue more than 50 minutes. Okay? All these parameters saying it is abnormal. And abnormal, you should take a decision. You should re-evaluate the patient and intervention must be taken as an emergency. Okay? This is the last slide. I hope it will be beneficial for you. Thank you. This is my textbook on Amazon, Ops and the Guide. I'm Dr. Ala Musbah, Professor of Obstetrics and the Gynecology Faculty of Medicine, Mansoura University.